Hello, good morning. Welcome back to the Greenwald Pavilion. I'm Julie Rovner. I'm Chief Washington Correspondent at KFF Health News, and I'm host of our weekly podcast, What the Health. And I am happy to be back here for a second panel today to talk about the future of the Affordable Care Act. The ACA turned 15 this year, which makes me feel very old, yet its ultimate fate is still TBD. Even as we speak, the Senate is preparing to debate a bill that would make some of the most significant changes to the health law since it passed in 2010. We'll get to those possible changes in a few minutes. As someone who covered the run-up, passage, and implementation and subsequent evolution of the ACA, often with the help of our two panelists, I think it's safe to say the law remains very much a work in progress. That shouldn't be that much of a surprise. Medicare and Medicaid each turned 60 at the end of July, and look at how much we're still debating those programs. So healthcare evolves, as do the laws that help run it. So what does the future of the ACA look like? Fair to say nobody really knows, but few people are better positioned to take educated guesses than my two panelists here. Nancy Ann DeParle is managing partner and co-founder of Consonance Capital Partners, a healthcare investment firm. During the Obama administration, when the ACA was passed and implemented, she served as assistant to the president and deputy chief of staff for policy, as well as director of the White House Office of Health Reform. Earlier in her career, during the Clinton administration, Nancy Ann ran what is now the Centers for Medicare and Medicaid Services, and before that, she served as Human Services Commissioner for the state of Tennessee. Lanhee Chen, on the end there, is co-chair of the Healthcare Policy Working Group and the David and Diane Steffi Fellow in American Public Policy Studies at the Hoover Institution at Stanford University. Do you have that all in one card? He's also a partner at the Brunswick Group, a global critical issues advisory firm. He's been a policy advisor to 4 Republican presidential campaigns, including serving as policy director for Mitt Romney in 2012, and also worked at HHS during the George W. Bush administration. We're going to get to the possible impending changes to the ACA in a moment, but first, just to set the stage, I'd like you to both begin with this question. What parts of the ACA do you think have worked the best, and which parts have been not so successful? Nancy, why don't you begin?
Thanks. Well, yeah, it's hard to believe it's been 15 years, and as I was sharing with you, I'm now dealing with using the provision of I used the provision of the ACA that allowed you to, your children to stay on your plan until they turn 26, and I have a boy turning 26 next month, so I'm working through those changes. But I do think it's important to go back 15 years and think about where we were when this all started. And as you'll recall, both of you, at that point we had 50 million Americans who were uninsured. Employer premiums had more than doubled over the decade before that. Employers were dropping insurance. Every year there would be a study come out of Kaiser, where you work, Julie, KFF, or others, noting the number of employers providing insurance was dropping. And then, if you were lucky enough to be able to get insurance, often if someone had a pre-existing condition, depending on what state they were in, it could be very, very expensive. Or if you were a woman, in some states, in the Dakotas, as I recall, they rated women in the individual market 27 times men, so they made 27 times the premium. So we had markets that for the so-called individual market for working people that just weren't working. And that's what President Obama set out to try to do something about, working with Congress. And so the main objectives were expand coverage, bring down the rate of healthcare cost growth, and improve quality. And, you know, I give the Affordable Care Act high marks on all of those. We certainly expanded coverage. We're right now at our all-time low uninsured rate of 7%. It's not perfect, but it's much better than where we were at 14%. We have 24 million people in the Affordable Care Act marketplaces. We have 21 million people or so on Medicaid. And so over the course of the 15 years or so, you know, 50 million or so Americans have been helped just by coverage. And then when you look at the private markets, those of us who are fortunate enough to have employer-sponsored coverage, we have preventive benefits that have made a difference on both the rate of cost growth, which for employer-sponsored insurance has been the premiums, the increase in premiums was half of what it had been before the Affordable Care Act. So that's not nothing. Your premiums are still going up, but it's better. And with respect to quality, the coverage of preventive benefits, the coverage of contraception, the coverage of all those things really improved that. So we still have a ways to go, but I'm very proud of it. And I would also say the process, it was long. It certainly wasn't rushed. It took over a year. And that doesn't even talk about the 10 years before that, when Strange Bedfellows and other groups were working bipartisan to come up with what should this look like, in part building on something that Lonnie's former boss, Governor Romney, did up in Massachusetts. So there'd been all this effort for years and years. So the process was long. We had 131 congressional hearings. The markups of this bill were the longest in history. You remember that?
I sat through most of them.
One of them ended on, Christmas Eve. So that process was good. And the policy, while not perfect, I would never say that it was bipartisan in many ways. There were many Republican ideas that were great ideas that they offered. I think there were 121 of their amendments that were added onto the bill. So what can I say? I'm proud of it. As you'll hear, there's lots more we need to do, but that's what I think.
What didn't work so well? I think you'd mentioned long-term care. That was
Yes. So we didn't set out to try to solve the long-term care problem in this country. There were members of Congress, including Senator Ted Kennedy, who really wanted to make a dent in that. There was something called the CLASS Act, which is an acronym, CLASS, and I'm not sure I could even tell you what it stood for now. Services and supports with the last two S's, right? But anyway, it was to try to help people buy into long-term care insurance so they would have either home-based or, if they wanted to, funding that they could use for institutional care. And actuarially, as written, the actuaries at HHS just decided it didn't work, so it didn't go forward. So that's sitting out there as a big problem waiting to be solved, is, long-term care insurance, long-term care supports. And then I also think the markets worked well, and I give the insurance industry a lot of credit for basically turning on a dime. They'd been operating under the law as it was, that I won't even say incentivized, that the only way they could survive would be to rate people and decide who was healthy and who wasn't, and give higher rates to the people who weren't, because the markets didn't require everyone to be in. That's part of why we had the so-called individual mandate requiring everyone to be part of this. We can have a discussion, I think we will later, about why that's no longer in the law, but it was extremely unpopular. And if I had known there was a way to do this without that, I told President Obama after this was all over with, he should have me drawn and quartered, because we insisted on that, and he was willing to do it because we all believed that's what you needed to do. It's kind of a shame that we wasted so much energy on that. There was not a public plan. People had differing views about whether that was important to help keep costs down. I think the episode we're going through right now is probably going to cause a resurgence of interest in that. And we can always do more on quality, I think. That progress has been made, but we need to do more. We moved from payment for basically reporting to payment for performance, and we've built a foundation there, but we need to do more there. And then behavioral care, I think that has been a bit left out of the equation as well.
So, Lonnie, as Nancy Ann pointed out, a lot of the Affordable Care Act was initially based on what Governor Romney did in Massachusetts in 2006. So I'm presuming that you think that there are parts of the ACA that have worked okay, right?
Yeah, I think the concept of trying to create a common conversation around the importance and value of coverage, I think that's something that we probably wouldn't have had if we hadn't had that debate. I think one of the things that I regret most about the conversation is that it's not like healthcare's become any less polarizing since then, right? I think that, and not that the ACA was claiming to deal with the polarization problem, but I think that raises some of the issues that we continue to have. When we have healthcare debates, it feels like a lot of times we're talking past each other. Mm-hmm. And there were these sort of common understandings that I think in some ways the ACA was meant to build that I think were probably a positive for the system, and if we continued down that direction would have been very favorable. I think, the concept of migrating away from a system where fundamentally we pay for volume to one where we pay for quality or outcomes is a great concept. I think that we have a long way to go. And again, the ACA was not meant to be chapter and verse on that, but I do think that if we think about where we have to build over the next couple of years, I think we have to pay a lot more time and attention to how that process has been and the things that we can do to continue to animate that process going forward. I think that the ACA, for all of its accomplishments, I think has created in some ways an over-reliance on Medicaid, in my view. Some of that was maybe intentional. Some of that was probably because there weren't a whole lot of other ways to do things quickly. And I think as a result, the Medicaid program has now come under a lot of attention, and there are parts of that scrutiny that are warranted, in my view, parts of that scrutiny that are overly politicized and probably unwarranted, in my view. But nonetheless, I think that if you were to look at the ACA and how it effectuated most of that coverage increase, it really was through Medicaid. And as a result, I think has created the platform for us now to be having this conversation about a program that I think a decade ago, very few people would have had extended conversations about, maybe some governors and people at the state level, obviously. And then the only other thing I would say is that I think that some of the market reforms point the way toward what I hope is an effort to address some of the remaining challenges we have for people who are still in the individual markets. Many of those markets, small business markets, fall into the same category. I think they're still not functioning particularly well. And I think one of the challenges we really do have is around people who are working poor and maybe kind of come in and out of Medicaid and into private coverage, and they end up with these like series of serial arrangements that they're bouncing from plan to plan. It's not a particularly good customer experience for them, and it's not particularly good for the system because they end up in some cases dual enrolled and they become a fraud flag when in fact they're not engaging in fraudulent activity. They're just literally having changes in life circumstances. So how do we create a system that is better able to enhance the portability of coverage for people, particularly at the lower end of the income scale? I think that's an area where we really need to be giving a lot more thought and time and energy to. But I guess that my overall view is there are some things there that there's some things in the ACA that I think laid a good foundation and platform, and other things that I think haven't worked as well. And I think particularly the over-reliance on Medicaid is an area that I take issue with.
You want to respond?
And on that, Lonnie, I agree with you that the marketplaces to purchase private coverage for people of low income and working people, that was an important foundation, and we need to strengthen it. We agree on that. On Medicaid, I don't know that you and I have ever talked about this, but from my vantage point at the White House, I originally, in the spring of 2009, was focused on trying to do it through the marketplaces.
Right.
And I remember where I was standing in Nashville visiting a friend when I got the call from CBO saying,
Yeah.
okay, that's a nice idea, but this is how much more that costs than Medicaid.
Yeah.
And we paid for our bill through mostly healthcare cost reductions, and it just wasn't an option.
Yeah. Yeah.
But I really didn't think about it the way you're thinking about it.
Yeah.
It's important to hear that.
Because I think that we have many more blunt force instruments to control cost in Medicaid than we do in markets, right? And by the nature of markets, there is
setting prices, for example.
Yeah, well, exactly. And so I totally understand the rationale, and we can have a separate discussion about CBO-driven policymaking, which is the bane of a lot of people's existence, particularly like right now. But again, with any large piece of legislation, you're going to have to make compromises, and you're not going to get your ideal state. And it's amazing to think about 60 years on with Medicare and Medicaid, we are still undergoing some pretty significant transformations in those programs. But one thing that I think is fairly impressive about the ACA is the amount of political durability it's gained over time. I think early on, there were a lot of efforts, and obviously we went through a series of repeal votes in 2017, but there was this sense early on that it was quite vulnerable. And I think if you look at it now in 2025, very few who observe politics and look at the political data would argue that it's vulnerable. And I think that's an interesting accomplishment. It's not something I would have predicted. I think that is the benefit, by the way, of doing lawmaking by law as opposed to executive action. Is it retains a level of historical durability. If you look at, aside from healthcare, if you look at any policy area, there is significantly more durability that comes from having the buy-in of the legislative branch in any public policy change. And that's one thing that I think the Affordable Care Act has benefited from.
And yet, I want to turn to some of the impending changes, which I
Right.
think is about what you were going to say. They're both in this big, beautiful bill that the Senate is perhaps going to take up later this week. But the Trump administration has already moved on its own to make some pretty significant changes to the ACA, including things like shortening the enrollment period, requiring more verification of income, and increasing the amount of tax credits that would have to be paid back if people underestimate their income. Plus, unless Congress acts, the additional subsidies that led to the doubling of enrollment in the marketplaces will expire. What impact is this going to have on the law? I mean, Congress is not debating what they're calling a repeal of the ACA, but these would make some pretty big changes.
In some ways, I sort of wish we were debating that, because I'm heartened by what Lonnie said. I hope that he's right. He's very smart. But to me, I struggle to find anything positive so far for either the Affordable Care Act or for health care. I've taken to calling it the big, bad, backdoor repeal of the ACA, because to me, a lot of the things that are done in the name of curbing waste, fraud, and abuse, and I guess reducing the deficit or paying for the tax cut, really do undermine the marketplaces. And so my question is, will they be able to withstand what some are saying could be as much as, I think the Urban Institute or someone estimated 75% premium increases that we'll be hearing about in October. Those are big disruptions to the market. The plans that are left in those markets will have to be turning in any day now. I think their proposed rates, and the actuaries would be, I won't say crazy, but they'd be unactuarial to not build in a lot of additional premium dollars for that. So it's very worrisome to see all of that. And as you say, the cuts in the navigators, the changes to the enrollment period and constraining it to 6 weeks, in the bill, the changes to auto enrollment, making it much harder and creating hurdles for people to get in and re-enroll. To me, it feels like you and I were both around. I'm not sure Lonnie probably was still in graduate school, but when Speaker Gingrich proposed the contract with America, and they had footage of him saying, we're going to let Medicare wither on the vine. That's what this feels like to me. So that's one sort of metaphor. I have used the metaphor for the Affordable Care Act that it's like a Timex, which I don't wear anymore, and maybe nobody in here does. One of my partners wears a Timex. It takes a licking and it keeps on ticking. And I'm hoping that's the case, but I am very worried.
Yeah, I mean, look, I think that the political salience, I mean, again, I don't feel like there's a lot of appetite to address some of the really fundamental regulatory changes that have come, in part because people have gotten used to it, right? And I think that politically, that was always the most sensitive part of any effort to repeal the law, was the notion that you were trying to affect, for example, the modified community rating guaranteed issue provisions that were passed as part of the law. I do think it's the case that the marketplaces have never functioned optimally. Even in my mind, from day one, there have been issues around the affordability of coverage. There have been questions around the benefit package, the structure of the benefit package. So all of those are really fair questions that I think if we had a more technocratic society, we'd probably be tweaking and thinking about ways of affecting those changes. We haven't. I do think that in the current discussion, look, it's always politicians are always very interested in cutting waste, fraud, and abuse. They love talking about it. But when you really kind of climb into that rabbit hole, the parts of the system where there is, I mean, first of all, there's three very distinct concepts. Even if you think about the academic research, right? When you talk about improper payments, that's a different issue than just sort of straight up outright fraud, people enrolled in multiple. And to the degree that there are people who are enrolled in multiple coverages who aren't eligible for those, I think you'd get like 85, 90% agreement, they shouldn't be enrolled in multiple coverages. So if we have a way of dealing with that, great. The improper payments thing is a little bit harder, right? Because there's some amount of it where there is gaming of the system. There's certain provider behavior. There's certainly plan behavior in some cases that you have to look at. So that's one where it's like, okay, I could see us trying to deal with that. But what you're trying to do is to use a blunt force instrument in the form of this reconciliation bill to address a series of what are really targeted concerns about the technocratic implementation of a law. And that's always going to create a series of challenges in my mind. This reconciliation bill is many things, but a work of art it is not. And so the idea that you can look at it and think, well, you know, what is it trying to do, and this is really going to solve any problems, it's very hard to see that, because at the end of the day, it is a tax bill. It is a bill to extend the Tax Cuts and Jobs Act with other stuff that is part of the conversation by necessity of the reconciliation process. So I think we have to see it in that way and understand now, okay, what are the different ways that the Republicans in Congress are going to deal with the challenge they have, which is to create a fiscal platform to pay for these tax cuts in an ideal world.
What do Republicans want from healthcare these days? I mean, there was sort of the big joke about their whole repeal and replace is that they never had a replacement ready. There was never any agreement on if you repeal the ACA, what it would be replaced with. Now no one's even talking about it.
Yeah, and I mean, listen, I think that's there are a lot of people who have been thinking through what the elements of it all feels very dated and antiquated now, but what the elements of that market-based system would look like. I guess what I would say is that we have seen a complete change, in my mind, in the ecosystem, in the right-of-center healthcare policy ecosystem in the last couple of years. And by the way, some of this actually postdated President Trump's first term in office. I really think some of this has come over the last couple of years. And you see it manifest. I mean, the way that I've talked about it in the broader political context is the influence of populism in the Republican Party. And I don't mean that pejoratively, I mean that like quite literally, that the populist impulses in the members of Congress that I talk to are much stronger now than they've been at any point before. So that colors how they view certain healthcare programs. Not the topic of this conversation, but we were talking about Medicare Advantage earlier. I think Medicare Advantage is a great example of where the coalition that had once existed doesn't really exist anymore. And not for any other reason. It's not like people sort of woke up and figured out that there were things about Medicare Advantage they didn't like. What they didn't like is they felt that a bunch of corporations were profiting off the program. And that's really what it comes to. If you get into a conversation with these members and you ask them, what is it about MA that troubles you? They say, well, I just don't like the fact that you've got these big insurance companies making a bunch of money. And it's like, okay, well, but tell me about do you have an issue with the prior authorization? And they kind of give you a blank stare as though you're asking them about a fast food order. And so this is the challenge that we have, is that the ecosystem has changed a lot. So our understanding of where Republicans are now is very different than where it was a couple of years ago. And I think there are still some who are working through solutions. I mean, we obviously have a project at the Hoover Institution that's focused on that. But I will say that as a general matter, the conversation about healthcare now is not about policy, it's about politics. That is really what's driving this conversation. It's a political conversation, not a policy conversation.
And on that point, one of the troubling things to me about it is, and your question's the right one, Julie, what do they want? And the 10 years prior to the Affordable Care Act, there did seem to be a consensus around, okay, yeah, we need to get everybody in the system. That will enable us to do some of the things we want to do to bring down cost growth, and employers are paying a hidden tax on behalf of people who don't have coverage. There was this understanding of the way insurance markets work. And now I hear Republican senators say things like, why do we need to cover young, healthy people? It's like they don't understand. We've suspended our knowledge of how insurance markets need to work. And I would think that would have been an important sort of article of faith for them, because that's what enables the private sector to be involved in this.
Right. Well, there I think it's a question of how much of it is compelled versus driven by what. I mean, I think if you were to ask like a market-oriented person, they would tell you what would incentivize people to gain coverage is that if that coverage becomes affordable at a point where it makes sense rationally in their economic calculation. Now, we can debate whether that's true or false because a lot of times younger people would rather spend money on like snowboarding lessons
Or a new
than
iPhone.
on or a new, whatever gadget technology that I know nothing about. They would rather do that than buy health insurance. So that's why this concept of the compelled.
We had the individual mandate.
Yeah, I mean,
right?
so you kind of understand that there's this debate over what actually. So if you look at it from a health economics perspective, like, yeah, if you create enough sort of market attractiveness, then yeah, you're going to have a higher take-up. But is it going to be at the take-up level you need to wash out that other risk? That's an actuarial question, and it's a tough one to answer. But I think you're right that the basic conversation has shifted a lot since 2013?
And it's the politics of healthcare have shifted even from where they were before.
Well, I have a politics question for you, which is pointing out that there have not been a lot of changes made to the Affordable Care Act since it was passed, but almost all of them had to do with taking away the things that paid for it. As you pointed out, the original bill was estimated to have been financed by mostly taxes on, people or stakeholders in the healthcare system who were set to make more money because of it. The idea was they would give some of it back to help finance it. We no longer have the individual mandate anymore because that was unpopular. We don't have the Cadillac tax that was going to deter very generous health plans anymore. What does that say about the politics of healthcare going forward, that Congress seems to be sort of able to pass things that add to healthcare, but not things that would pay for it?
Yeah, contrast that with the Medicare Modernization Act,
Right.
which gave seniors a drug benefit and wasn't paid for, extremely popular.
Passed by the Republicans, largely.
Exactly. So, the hardest part of the Affordable Care Act was getting agreement around the pay-fors. And I'm proud that we did it. At the end, it cost $1 trillion less, I think, by the last projection I saw than CBO had thought. It did save money, reduce the deficit. But gosh, was that hard. And you left out the dreaded IPAB, which I promise not to drag everyone here down into that conversation. But, the Congressional Budget Office, Lonnie, said that...
This was the Independent Payment Advisory Board, and I can't believe I can still remember that.
I can't either, but they would not give us credit for, and it became the death panels of the August recess, but they would not give us credit for savings unless we had a mechanism like that to automatically require savings in the health entitlements in the future, and it never got off the ground. So what does it say? That anything cutting the budget, certainly in healthcare, is very, very hard to do. And I think if this bill passes with a big tax cut and no pay-fors, it's, you heard Speaker Pelosi, Lonnie wasn't here last night, but she talked about something that seems very quaint, but PAYGO back in the day, and there was strong bipartisan agreement. And then it continued up until the ACA. We had senators who would not vote for it unless it was paid for. I'm not sure that exists anymore.
Even
Now, maybe that makes it
Democratic side?
easier for those of us in health policy to not have to do that, but I don't think it's a good thing for our children.
Well, look, we've been gorging ourselves at the fiscal buffet for a long time now, and it's like we don't think there's any end to the resources, and the reality is that there are, and we're seeing the recent trustees report on the Old Age Survivors and Disability Insurance Trust Fund as well as the Medicare Trust Fund demonstrate that the days of the continuing, sort of unending fiscal buffet are coming to an end, or at least they should. And that should be a recognition amongst people who are in the policymaking class. But I will tell you that there is less than no appetite amongst policymakers to acknowledge that reality. That's not true. They'll acknowledge the reality, but I think to actually do something about it requires a very different level of political willingness. And right now, there's no political willingness to deal with it.
bipartisanship, too.
It does. I mean, you have to. Who was it that said, if you're going to jump off a cliff, make sure you're holding hands with someone when you do? And in politics, I think that's a good rule that you got to have somebody that you can drag along with you if you're going to make a major change. And we're just not seeing a level of interest in having that conversation. I think that there is a lot of dialogue and a lot of rhetoric about, oh, look at how awful our fiscal condition is. We have to get this fixed soon. And then the next logical step would be, well, what are the steps we're going to take to make sure that we're making the changes necessary? The problem is then the end of that sentence tends to either be nothing or a series of policies that probably won't make things better, right? And so I think that's the challenge that we're facing right now.
What do the Democrats want to do? I mean, they've been sort of managing to shore up the Affordable Care Act to the extent that they can, but I mean, there's still a push on the left-hand side of the spectrum, for Medicare for all or some kind. I mean, nobody's happy with the healthcare system the way it is.
I think that's true. I mean, I think, as you heard last night, a lot of the Democrats' energy has been focused on strengthening, saving the Affordable Care Act after the 70-plus repeal bills passed the House. And I'm not sure there's agreement. I was somewhat mystified and crestfallen to see the number of people who supported Medicare for all in the last primary season, and I don't, in the Senate, candidates for president, many of them. But it does. Lonnie talked about the change in the center right. I think there's been a change in the center left as well. And you have leading progressives who say they would not have voted for the Affordable Care Act. And a number of the people in the House caucus weren't even there, and they don't support it. So I'm not sure that I can speak to what they want. I only know that what we tried to do was build on the current system. We did not try, as you heard Secretary Sebelius say last night, to start from scratch and design the perfect system. We decided to try to take the individual market and try to fix what was broken and build off of that. And that was the hardest thing that I've ever been involved in. So doing something bigger than that, which all of these ideas are, I'm not sure, I'm not sure who those people are, but good for them.
What about Medicaid? I mean, we're obviously looking at potentially large cuts to Medicaid. That's going to have a trickle-down. I mean, that is part of the Affordable Care Act, and that's one of the things that they're looking at. But also, it's going to have a trickle-down impact on the marketplaces, too, if that many people lose Medicaid. And these are, Lonnie, these are mostly going to be in Republican states. Has this not sort of penetrated?
Well, I think if you talk to governors in those states, it's definitely very. I mean, you had a panel with some former governors this morning, and I think that the level of awareness is there. I think that they feel as though it is one of those things that they have very little control over. Because again, this is not a policy conversation; it's a political conversation. So they're trying to make a policy argument. And to some degree, a few of them have migrated it into the political argument, which is, look, you don't want a bunch of people who did have these coverage arrangements to find themselves without them, and then that's going to reflect poorly politically. It may not reflect poorly politically on the president, but it will reflect poorly politically on members of Congress who have to run in particularly competitive districts next year, and that is an important concern. So I guess I would say that the rubber always hits the road with governors, and they're the ones who have to make it work. I don't think that there are a lot of governors now who would look at you and say that they've got an ideal situation when it comes to Medicaid currently. It is always going to be the biggest headache that they're going to have to deal with within their fiscal construct that they have to deal with. So if we were really having a policy discussion, we would sit down and say, what are the fundamental changes that we would want to make to ensure that the program serves the people who it intended to serve, and that might include some percentage that were incorporated as part of the Affordable Care Act. But then how do we make sure that for a whole series of other Americans for whom Medicaid may not be the ideal fit, we are providing them with appropriate coverage arrangements or providing them with appropriate options so that they're not stuck in this fiscal limbo, which is going to be created by any changes to Medicaid at the federal level will cascade down. They have to by definition. So the rubber will really hit the road with these governors. And I do think the governors have tried to make the case. I just don't think it's going to be compelling at the end of the day. I think this bill passes eventually in some form, shape, or form. Whether it looks exactly as it looks today, probably not. But the substantial elements, I think, are there.
Are you surprised? I mean, we're not hearing that much from the governors, though, which has surprised me.
It's been quiet. I mean, you look at the numbers, and as you said, Lonnie, I think it's like 2 million from Florida, or maybe it's 2 million in Texas, 1.7 million in Florida. And you mentioned this, Julie, but it's going to affect certainly the individual marketplaces and the working class, lower income people who buy coverage now through the Affordable Care Act or get it through Medicaid. It also is going to have impacts on the markets above them, the employer-sponsored insurance market, and the prices that they get for premiums and the prices they pay at hospitals. You know, and I don't know who. I sort of agree with Lonnie. I don't know that President Trump owns that, but it sort of seems to me like he should. I don't really know who else should own it. Should a governor own that? You know, they didn't do it.
Where is the next generation of sort of policy nerds in both parties coming from? I mean, I spent 30 years on the Hill with committees basically doing a lot of this work under both Republican and Democratic leadership, really talking deeply about healthcare policy. I'm not seeing that anymore on either side.
This will be very intuitive to you because that is, I think, a big challenge we face right now, which is a significant loss of expertise from the Hill and people who spent a lifetime working on these issues, who have a deep understanding of them and a point of view, have been replaced by people well-meaning, they just don't have that level of experience. So they're having to get educated about a lot of these things and then develop a perspective and point of view. And what hasn't been available to them, in my view, is one, sufficient opportunities to get to know staff from the other side of the aisle with whom they would work on these issues. But secondly, to really spend time to stop and study and think through what is the right posture that I should be taking as I advise my boss. So they're getting all this, they're getting a ton of information, don't get me wrong, but I don't think that they have the time and space to process in the way that maybe we had in the 90s and 2000s.
Right.
And I mean, I just think that expertise has largely fled. And it's fled because, when you're making $80,000 a year as a senior congressional staffer, or, some amount, maybe a little more than that, you look at the opportunities on the outside, and at some point, those become too attractive.
Yeah, and there used to be groups that sponsored, get-togethers and trips and all that, and foundations did it. Some of that has been now viewed as being ethically challenged. Maybe Aspen, I think Ruth is here, maybe Aspen should do something.
All right, well, I'm going to turn it over to the audience now. I know you guys have questions. There are people with mics, so please wait until a microphone gets to you. Go ahead in the back.
Thank you. We've all rightly been focused on the threats to the ACA now, but I'd like to ask you a different question. Suppose a candidate for the next presidential election appointed you three as the co-chairs of her campaign for health reform with the goal of covering the remaining 8.2% of Americans who are not currently covered by any insurance. What would you do? What would you advise for a program that would be enactable, practical, and effective?
Well, I'm just a journalist, so I don't have to answer that one. What would you guys do?
Well, the problem is a lot of the people that you're pinpointing who have remained uninsured are undocumented people, people that are working here, living here, in some cases paying taxes, but they weren't part of the Affordable Care Act. Only those who are lawfully present are covered, and they will be kicked aside as part of the Senate version of the reconciliation bill. So we'd have a big task ahead of us, and I guess we'd have to somehow convene a bipartisan group to do immigration reform first and agree that that was okay.
The only thing harder than healthcare is immigration.
Yeah, and maybe the only other thing would be I think you're not talking about coverage. I don't see us getting to an agreement where we agree to cover under the marketplaces those people, except the way that it was happening in states like California and others. They were doing it, but I don't think they can do it on their own dime if they're not getting any federal assistance. So I think then you're just talking about federally qualified health centers and other ways of creating access but not coverage. I still believe coverage is important, but I'm not sure there's an agreement on that population.
Yeah, I mean, that is the toughest part of this whole thing, and the most politically fraught.
You live
as
in
well.
California, so
Yeah,
you
I
see
mean,
it.
it's been the focus of the debate that we've had in my home state, and it's been a massive challenge, right? Because if you look at that percentage that remain uninsured, there is a sizable number of them who are undocumented, and I think that's a problem. Look, I think there's always going to be some percentage. I mean, even after the Massachusetts reforms were implemented, you were still looking at that sort of 1.8 to 3% range, where you had some percentage of the population that remain uninsured. The number goes up and down over time, but it remains like fairly. There's always going to be, in a free system, you're going to have people. By free, I don't mean fiscally free. I mean just a free agency. You're going to have some percentage of people who make the decision that they don't want coverage unless there's a penalty to be paid, and even then, the penalty may not be a sufficient inducement to coverage. So there's that issue, and then, but I do think it really is about the undocumented, and then of course you've got the non-expansion states, and there I think there are probably some marketplace reforms and some issues that get at this problem of folks who are in Medicaid eligibility, sort of by rules would be there. Other times they're in a private plan, and they sort of have to go back and forth. I think getting a little more stability around that.
You alluded to that, and that's what I think I would try to persuade our candidate that she should work on that instead.
Absolutely.
And that won't be easy at all. And then I would say let's continue to work on affordability. Let's continue to work on quality. Those are areas and outcomes where I think there is some bipartisan room for
and frankly, where there's a
compromise.
huge need as we think about how physicians are compensated, how plans participate. I mean, there's all of these questions around the structure of our healthcare system and what we're really paying for that we have to get right. And that should be stuff that's relatively less polarizing, I think.
Another question? We're here.
Hi, Ryan Levy, reporter with Trade-Offs. I'm curious, talking about coverage, and you talk about Nancy Ann saying you still believe there's value in coverage. I've been hearing a lot more, especially from folks on the right, questioning that and really saying,
So have I.
What is the value of coverage? Is that do we actually have the evidence that shows that that is improving outcomes? I'm curious for both of you, I guess maybe Nancy Ann, kind of what convinces you about that, and Lanhi, I mean, both what you think about this and what you're hearing in more conservative circles about that and kind of the value of coverage.
Well, I'd say two things. One, there was a consensus among policymakers that in order to get the benefits of trying to get people access and also bring down the rate of healthcare cost growth, you had to get everyone in the system. Otherwise, hospitals are bringing in uncompensated care. Premiums are higher for the employer market, for the self-insured market, because they're paying the premiums. They're giving hospitals more funding for caring for the uninsured. So there's a policy reason for it. My second reason, though, that I think that coverage is valuable is I told you I have a 25-year-old about to turn 26, as well as a 23-year-old, and I can tell you they're the prototypical healthy young man that I hear about when people are now making the argument about why do we need to pay for them? It's expensive. They don't really go to the doctor. Well, they should. It turns out there are things that can be prevented. Hereditary high cholesterol needs to be diagnosed when you're young. You don't want to wait until you've had damage to your heart. And so those people need to be part of it, not just for all of us, because I think it does improve the premiums and improve coverage for all of us if we're all in it together. But also I think it does pay dividends in terms of getting the preventive benefits, getting your health in order as opposed to waiting until you have problems.
Yeah, I think that some of the questions about the efficacy of coverage have largely come in the Medicaid context, where there have been increasing stories about people who have coverage through Medicaid at state X or state Y, and they can't see a provider timely, or they can't get access to care because fewer and fewer providers are willing to accept the reimbursement rates that we're seeing, states have tried in some ways to get at this problem with various backdoor solutions, some of which are going to be foreclosed potentially by the reconciliation bill. But what I think is interesting there is we should be having a discussion in my mind about the efficacy of coverage. I don't think it is bad for us to have that discussion. In other words, coverage in and of itself, quality coverage is what we want, not just coverage for the sake of coverage. And I think that the question around Medicaid has jump-started a series of conversations about the value of coverage that can't be used in a way that is helpful to improving health. That, I think, is an issue we have not resolved yet. So I wouldn't be so quick to dismiss those who question the value of coverage in and of itself. I don't necessarily think that that's a conversation we should be avoiding. I think we should really have that conversation about how do we make sure, for example, if someone is on Medicaid somewhere, that the coverage they have is actually useful beyond the world where if they didn't have that coverage, they were going to show up in the emergency room anyway, right? So if they're going to show up in the emergency room anyway, okay, then the question becomes like, was there something we could have done or a kind of coverage we could have given them where we could have avoided that outcome? That is a worthy conversation to be had.
And I think to that point, there was a passionate debate. Speaker Pelosi talked about this last night when the House and Senate were coming together to try to work through the differences in their bill before we realized we didn't have 60 votes. But Henry Waxman, a leader in all of this on the House side, the chair of the Energy and Commerce Committee, made a passionate appeal to increase primary care rates in Medicaid.
Right.
And he got it in the bill. So the part that was the reconciliation bill in the Senate included increasing primary care rates.
But only temporarily.
But it was temporarily, right. So that's a conversation that we need to have. And I do believe, Lonnie, there's evidence that having access to primary care does make a difference, and you can show a difference in outcomes.
Access to primary care certainly does, yeah.
So that's a conversation that we should have. He was right.
Another question.
Thank you. Going back to quality of healthcare, this morning Governor Cooper mentioned the Healthy Opportunities pilots that are paid for by Section 1115 Medicaid demonstrations. Over the past couple of months, you know, there's been reports from local legislators in North Carolina, maybe this isn't working as well as we want it to. So I wanted to ask the question, with the probable scenario that has been described that this one big beautiful bill moves forward in some version of its current priorities and there is less funding available from the federal government for the Medicaid program, how do programs that address social determinants of health and health-related social needs survive, financially speaking?
Well, that one's really interesting. There was bipartisan support for that. It was part of the Medicaid expansion. And I don't have the numbers at the tip of my tongue, but if Mark McClellan were sitting here, he'd be citing dozens of numbers. They'd set it up right in that they did evaluations from the beginning. And he says that it can already show savings from creating this team-based care and helping people with housing and food and other things, and he cited numbers that were impressive. So I'm hoping that that will win the day, carry the day in North Carolina. But if there are big Medicaid cuts to the state, I think that'll be a problem.
Look, I think the reality is a lot of states have used, whether it's a waiver authority in 1115 or some states have begun to experiment with 1332 waivers when there's a need to bridge different populations in particular. And I think that the things that states have done are exactly the things states should do, which is to use those waivers to experiment. And in an ideal world, if you believe in federalism as I do, one of the things that you look for is what works and what doesn't. What can we replicate and what can we throw aside? And I think that the shame of this funding cascade would be if programs that are proven to be effective don't have the opportunity to continue. Now, there's a lot more debate around, for example, in California, we're having debate about CalAIM and whether that's the right approach. And I would gather that many people around the country who are not in California or not part of the governor's administration probably would say, we might want to take another look at that one, right? again, that's why we have this process, is because you want to have a way of seeing what works and what doesn't work. But it is unfortunate because, you know, a lot of these demo projects, I think, have produced some really interesting, and there's some interesting work Georgia's doing now as well. A lot of states have tried to move forward with what I think are really interesting ideas, and we need to continue to have that.
Mm-hmm.
We're out of time, but I'm going to exercise the moderator's prerogative to ask one last question. At the 2035 Aspen Ideas Health, are we still going to be debating the Affordable Care Act?
Yes.
I think so. I mean, Medicare and Medicaid are a great example of that, right? So yes, I think so.
Well, I will welcome all of you back then, and thank you very much, panel.
Thank you.